Thank you. And first, I'd like to thank the organizers and Marvin for inviting me. I think this is an outstanding and quite unique meeting, and I'm learning a lot. And I also learned quite a bit when I started preparing for this talk, because I have to disclose that this is not a primary research area of mine, but it's something that was already alluded to earlier today, that it's something we cannot ignore, and we should discuss that. So these are my financial disclosures. I should probably also disclose that I work in a completely socialized medical community, so my perspective on this is very much that the society bear the costs related to our interventions, so we can discuss that. Anyway, I think this was already also alluded to, that cardiogenic shock, we all agree that that's a very expensive disease that we are managing, and that will be the basis going forward here. So first, let's look at some numbers. When we talk about cardiogenic shock, the length of ICU stay in the US is 6 days. The total hospitalization stay is 9 days, and it's actually significantly longer in Europe based on the data I've been able to find. When we talk about the costs, I have only been able to actually retrieve data on cardiogenic shock in relation to STEMI. And here, the cost related to that is quite dependent on whether an aggressive invasive strategy is adopted or whether a non-invasive or less aggressive management strategy is pursued. So ranging from an average of $62,000 to $29,000. And in fact, interesting, these studies, there were no differences with these costs depending on whether the patient survived or not, and I think we should keep that in mind. So as a framework of looking at the cost and the cost effectiveness of our interventions in cardiogenic shock, I think there are sort of 4 scenarios that we do depending on the aggressiveness and the outcome of the patient. So not the aggressiveness of the patient, but the aggressiveness of our intervention. So if we're dealing with a very conservative intervention and the patient survives, we're going to have a low cost, and in any case, we're going to have a nice cost-benefit ratio. At the other end of the spectrum, of course, a very aggressive strategy based on PVATs and ECMO maybe, and the patient dies, we're not going to have a good cost-benefit ratio. And the most interesting ones are the 2 yellow ones, in particular number 3, which I think is the one that we should probably devote most energy to, is the patients where we apply an aggressive invasive strategy with survival. How can we optimize the cost-benefits ratio there, and how can we calculate it? And I'll get back to that, because that's really going to be difficult, as you will see. There is very little data out there directly comparing cost effectiveness and costs even with various strategies. And that's, of course, and I will repeat this later, it is a consequence of the lack of positive randomized clinical trials in this area. Now, there is data from the SHOCK-2 trial comparing conservative management with IABP. And in fact, when we look at average costs and average total hospital costs, they're higher with the IABP than the control group. But as you can see, the differences are truly marginal, around 30,000 euros in this study from Germany. So really, the IABP adds little to the cost in this randomized trial. And of course, this reflects that it's a very cheap device. But as this audience, of course, knows, the implementation of percutaneous VAT has exploded exponentially, both in the US and in Europe. And this certainly is driving costs. Also, we've seen extracorporeal membrane oxygenation here, our data, also from the US, and you can see the cardiogenic shock also has increased significantly the use of ECMO in this period. Now, we do consider ECMO to some extent a cheaper treatment than the PVATs, but remember the circumferential cost of ECMO, the perfusionist, the many days in the ICU, the added surgical procedures to implant, explant, it certainly is adding significantly to the cost, although the device per se might not be so expensive. And we can see that definitely here with also data from the US showing that even back in, I think, 2009, costs were exploding for ECMO in the US. And this is not just cardiogenic shock. about ECMO overall, but I'm sure if we were able to break it down, we'll see that for cardiogenic shock also. And then I think it's important to recognize, and we would try to analyze the field of costs in this area. It's not just about the direct management of cardiogenic shock. If we have patients with a cardiogenic shock that are treated with inotropes only and they die, of course it's going to be very cheap. If they survive and they go to medical therapy, yes, it's going to be cheap. But if they go on to a durable MCS or transplant, suddenly we have added costs that are not calculated for in the usual cost calculations. And the total therapy, of course, is going to be expensive. Obviously, it's great for the patient that they were able to go this far, but from a cost perspective, we need to add this in. And this complicates truly the analysis of cost effectiveness here. Of course, with the PVAD and ECMO, you already have expenses up front. And then, of course, if MCS or transplant is added in, you're going to add further to the total costs. So costs with cardiogenic shock are high, especially when you use PVADs or ECMO. And the problem is that in the absence of randomized clinical trials providing exact information on the efficacy of these different treatment strategies, apart from what we have from the shock trial with PCI's CABG, the only way really to do any cost effectiveness analysis in the daily clinical practice and apply that to our clinical management is to exclude too high-risk patients from aggressive strategies. And that is not easy. There's very little data trying to address the different risk factors of poor outcomes and their effect on costs. The only one that I'm actually able to find is this one on ECMO, looking at the cost for various age groups. And while we know that the prognosis on ECMO for patients in the higher age groups obviously is inferior to those that are younger, the cost per day is the same. But in the end, we are not capable of identifying even the elderly patients that might do well with ECMO, and essentially that makes this cost analysis very difficult. So to conclude on this sort of this area where data paucity is huge, I think it's safe to say that costs related to cardiogenic shock are high, and they are increasing due to the increasing use of PVADs and ECMO. We have direct costs, such as the cardiac interventions, the VADs, ECMO, and we have indirect costs, such as durable LVADs or transplantation, that must be also added in here. The estimation of cost effectiveness of the different strategies and devices is really limited by the low number of positive randomized clinical trials, which really doesn't enable us to assess the effectiveness of so that part of the equation. And now finally, we definitely need cost analysis of the ongoing and future trials, who hopefully will demonstrate that we have better outcomes with very early aggressive intervention with PVADs or other MCS interventions, so that that in itself will drive lower costs by having shorter ICU stays. And we definitely need these data from these trials. And at this time, I would say that careful evaluation of high-risk individuals for aggressive strategies is the only way we can contain costs, but our tools to do that, as we have discussed several times here, are very far from perfect. So with that, I'd like to thank you for your attention.
So, Finn, at least in the heart failure patients, as a general rule, we know that actually there is a U-curve related to the how long you're actually admitted to the hospital and the outcomes. So the cheapest patients are the ones that are dead, and they also have the lowest readmission rate. Do we have any idea about, when we actuarialize this over a year's period, that somebody who you would want to randomize to a trial that they were kind of pseudo in shock and you kind of got them out of it with medical therapy, or you sent them home on dobutamine and they wind up getting admitted to the hospital 5 or 6 times after that the next year? Is it all a wash, you think, over the course of a year?
That's a good question, and I don't think we have any data to say that. And I was interested in Eduardo's comment earlier on how to deal with the patients that we actually managed to get through shock, sent them home, and not actually offering them follow-up or actually aggressive interventions to prevent them from coming back into shock.
Maybe another way of asking the question is what percentage of patients that we actually pull out of shock that don't get a mechanical device wind up being readmitted within 3 months?
I don't think we have that data, and we saw some data saying 25%. I think it's more, but I haven't been able to find those data.
So I think Finn's right. We were looking for a secondary endpoint in the randomized trial we're doing within the Penn health system, which is 3 hospitals now doing a randomized trial of ECMO within 24 hours Impella, randomized, all funded by Penn. The primary endpoint that we designed is freedom from transplant, VAD, or inotropes at 45 days. We wanted something acute as an endpoint or a midterm. But to your point, Dave, what's a secondary endpoint? We wanted a benchmark for readmissions. We couldn't find it. Even looking at our own Penn chart database, it was very muddy. So I think, I was going to ask this question, cost-benefit analysis is based on some benefit you're going to give the patient. I'm okay if the society, we're going to have a short-term benefit because you want to give an individual a chance, but I do think we should have registries for like Intermax, for long-term survival with a strategy of X, Y, or Z. And we don't have that. STS is 30 days. I don't know of any registries. Maybe Houston has sent a registry. I don't know of any data. Your point is right on, David. I don't know of any data.
I think this discussion is really appropriate. I know that when I was at Pitt, they were doing an analysis looking at their ECMO patients, and their preferred endpoint was actually 1-year survival. The idea being, if you're talking about a lot of costs, you want to try and get someone at least a year out. And so I think it raises the question, should we be looking at in-hospital 30-day mortality when we're thinking about these cost analyses? The question of rehospitalization, I mean, that's a massive question, because if you found out that by doing a slightly more expensive intervention up front, you save 3 hospitalizations and poor quality of life down the line, that's a big advantage. Likewise, if you have patients that live 30 days, go to a nursing home, and then die in 3 months after that, you could argue that that may not be an outcome worth spending $1 million on in all cases.
One other thing I wanted to amplify, it's interesting, is the problem is that it's not resource constrained. So we all running transplant programs, whether here or Europe, understand they only have so many to go around. Imagine if, for example, you said, okay, you can have 100 tandems a year or 100 Impellas. You might actually then think about, well, this person's been down for a long time. I only have, 5 more Impellas this month. And so we all like toys, and we have the individual patient. You want to do everything possible. But maybe a registry or some way to constrain the use so that you really think twice. Or you have bridge to bridge to bridge, and one patient has 5 machines. Because it's the whole idea that, well, we can't think about costs. Well, if we don't think about costs, eventually our administrator will come and show us the door, even in the States. What's that?
Is anybody here from Canada? Because you want to comment on some of the restraints, like at University of Toronto, that there's not an unlimited number of VADs you're allowed to put in.
Yeah, so I'm from Canada, so we pay a lot of taxes, but that's another shock symposium in itself. So Medicare pays for everything, but hospitals do have budgets. Like I was actually at your talk last week at the Toronto General, and the VAD, I think they have a budget for about 40 to 50 a year, especially now with destination therapy. They have to kind of cap it, but they do often go over it, and it becomes kind of in the hospital budget. But that's, to my knowledge, that's as much as I know.
But it's a good point. I mean, prioritization in healthcare is something that, in my country, it's a huge debate right now, whether it's the politicians or it's the physicians that should be doing this. And I'm not sure how to do this, but I do think that the money can only be spent once. So in the end, I think we should try and make sense out of this. And we do need to look at these costs. And I think it's very important to look at the follow-up of these patients. And I think it makes very little sense to put patients on ECMO and everybody throws in resources for them to obtain a 30-day survival without having appropriate measures to ensure that these patients actually do well afterwards, because otherwise it makes very little sense. In the Danish or the now Danish-German dance shock trial and danger trial, the outcome is survival at 6 months, which I think is better than 30 days, but still somewhat on the short side, and definitely longer term follow-up will be necessary also there, I think.
Finn, I'm just going to give you one anecdote, then I'll give the phone to Ali. I had a patient who basically was sent to me a year and a half, now it's his 3rd year with me, a year and a half after he was in fulminant cardiogenic shock with an LAD or left main infarct. ECMO was instituted, PCI was done. The timeliness wasn't clear because it was out of the hospital, the arrest, but he did well. Now, he comes back and see me because I didn't know him from anything. Another partner of mine took care of him, seen by the interventionalist, seen by an EP doctor, EF 45%, and he's got diuretic-resistant heart failure. And I didn't know what to tell him. What is a natural history of someone who's been in cardiogenic shock? Is the EF determined? Is that cardiogenic shock moment when he was in ECMO for 9 days, by the way. So he did take time to recover. So the question and I almost called Ali and other people that may see these patients in follow-up because we didn't have the experience. So I biopsied him because I couldn't explain shock, and we found amyloid. Now again, I come from a group at Hopkins where we biopsied everybody and their family members. That was our practice in fellowship. So he had transthyretin amyloid, and we're treating him for that. But I wonder what is the natural history of patients who have MI and cardiogenic shock.
Thank you. So regarding the cost, I think we talk about the cost, which is a very important point, but we have to look also at the efficiency. And that's an important point here. Even in the United States, we are paying much higher for the healthcare, than any other country in the world. But if we are not getting probably the quality is not much higher than other countries as well. If you look to the average age in guys in England, it's even higher than the United States, and paying probably 1/3 or 1/4 of the healthcare cost. We have to think about that here, and we as a physician, we should contribute to it, and not to wait for the administration to tell us what to do and what not to do. It's for all of us. We have to think about it to make the system more efficient, and there's a way to do that.
Ali, I think your point is very well taken. Now if you, we're all libertarians. We think that our families are entitled to absolutely everything, and you tell a family that that mom has a 1% chance of living and leaving the hospital. Typically, the answer I get now is, "So you're saying she has a chance?" No. So in Europe, you don't see that.
Yeah, rounding every day in the unit and looking to everything we are doing is going to add quality or not. To ask that question during every day, it's important. We're doing many of X-rays, many of CT scans without adding quality. I'm seeing that every day, and I'm fighting against that. We're doing that because the neuro guy said we have to do a CT scan. It's not going to add any therapeutic thing to the patient, but we have to do CT scan. We have to go MRI, and how frequent when doing that.
I'll throw in something a little bit philosophical, but having come from the Swiss system myself, and having worked in Germany, the UK, and in Holland, and now here in the USA, I think the problem with the problem that we'll probably be faced with trying to actually do studies with cost analysis and cost effectiveness or capping limits is that ultimately I think over-treating or under-treating are going to face the ethical questions, and are they superposable from one society or economical system to another? And that's probably not the case. Coming from
I don't think they are.
Coming from countries where medicine is socialistic, and the other extreme in the USA where it's not, even if we were to able to do those studies, I'm not sure that you can apply it from one system to another, and that's one of the biggest.
Switzerland, I think, even, I don't know what their actual financial status is. It's quite good, of course, but they act like they have even more money than us when I'm there. Germans will do everything. I think Americans are very much of the opinion that, if you're worried about liability, and that didn't come up at all, you don't get sued for acts of commission typically in the United States. You get sued for acts of omission. So, one is I didn't pick up breast cancer, and the other one is they died during surgery, and we did everything we could for mom. The first one will get you sued. The second one typically won't in the United States.
one thing we can do, though, which I think is going to be universally applicable or useful in all countries, irrespective of their healthcare systems, is to do proper clinical trials with the right endpoints also in this area, because that's, at least that is going to give us half of the cost-benefit equation, and then we'll have to fill out the rest depending on which healthcare society we're in. But we do need to know what the efficacy of the interventions we make is, because otherwise we're really looking in the dark.